Hey everyone, Dr. Matt Giller here. I'm here with Dr. Evans. She practices in Chicago, and we're going to talk about some very interesting topics. Thank you so much for coming.
Thanks for having me.
When I stopped practicing, that was when I should have started to learn a lot about co-management, anterior side, cataract, refractive stuff, and especially IOLs. I need you to give me 5 years in 5 minutes.
Got it. I think one of the biggest things we can do for our patients is provide a recommendation for the highest quality care, right? Maybe 10, 20 years ago, we would refer for cataract surgery with just a recommendation to take a cataract out, put a lens implant in, have them back for glasses. But nowadays, we can actually improve the patient's quality of life by getting rid of some of their dependence on glasses. So I always like to start out at the highest level of recommendation. You're talking to the patient and you find that they have a need for a lot of near tasks. They work on the computer all day, they like to sew, they like to read. Well, we can help that. If they have a cataract, we're already diagnosing it, we know they need it out. We can recommend a multifocal IOL so that they can better become independent of their reading glasses. When you have a patient in for their primary eye exam, yes, we can diagnose a cataract, right? We're great at that. We're great at providing appropriate surgical referral time for them. But we don't do a very good job of providing a specific IOL recommendation. The complexity of the information, the time we have in our exam room. But think about the patient, and when they arrive at their surgical consult, they're going to be just as inundated, times 10 as inundated as we are discussing the options, learning about those IOL options for the first time.
What are like the top 3 things that you really try to get across? Because that's a lot of information. You don't want to inundate them.
Certainly the IOL recommendation, the expectations for surgery, like risks and benefits and day of surgery expectations, and then very most importantly, the post-op expectations. We're looking at their corneal topography. If they have cornea astigmatism of 1.25 diopters or more, we're thinking already toric IOL. So we want to be recommending the best lens to correct this patient's refractive error after surgery. If we know that they are needing to do near tasks after surgery, that's when we want to talk about an extended depth of focus lens. So I talk to them about who their surgeon's going to be. I talk to them about how long the surgery is going to take, less than 10 minutes usually. No real limitations right after surgery. They're pretty much in and out, back for their 1-day post-op, usually with me, and they feel comfortable that they're going to see me right after the surgery. So we certainly want to take into account which IOL we're recommending and discuss what they can expect as far as visual outcome. There's one more thing I wanted to add, and I think one of the most important things is prepping the ocular surface before surgery. So it's really important to stain everybody at their primary cataract exam. So that's really important, is to treat ocular surface disease, treat dry eye before you're referring. The patients will be happier because of that. You're not going to get good outcomes with messy biometry, messy topography for cataract surgery.
How long are you finding it takes to treat the average patient's, ocular surface condition on average to get them back in the chair to say, okay, we're ready now?
Mild to moderate, I'd say let's shoot for 3 weeks. For those severe patients, it's going to take longer. Right there, you have to tell them up front that it's going to take a while, but you just need to communicate that with them, and they're okay. They appreciate you diagnosing that and treating that before referring. The surgeon also really appreciates a good referral. They can get cataract surgery referrals all day, any day from anybody. But if you set them up and provide the patients with expectations, already have talked about IOLs, already have talked about post-op, day of surgery, they really appreciate that. They appreciate a clean cornea when they come in for their consult. They will co-manage with you. They will trust you. You'll have a better relationship. The patient will be happier. It's just all around a better outcome.
It sounds like you're really starting with the goal in mind for the patient, not price or brand or things like that.
I never assume what a patient's financial status is. I always provide a recommendation for the best option. We never want to put you in a bad position. We always want to provide the best of care, but also thinking about your pocketbook. So They appreciate that.
Well, Dr. Evans, thank you so much for coming on. I appreciate it.
Thank you for having me.
Yep.